Dr. Dawndi.
Hi, I'm Chris.
Nice to meet you. How are you today?
I'm great. How about you?
Good. Today I'll be assessing your spine from about the base of your head to about your belt line. If I need to expose the skin in that area, is that all right?
Yes, it is.
Okay. If you don't mind taking off your shirt, I'm going to check the table, and if you'll have a seat facing the lines. Just scoot a little bit more to the end. There you go. All right. Alright, I noticed some stiffness in the L2, L3 area, so I'm going to have the patient cross his arms and then flex him and extend him to see how the joint or the interspinous space opens up and closes down. Alright, whenever I put the patient into flexion, the interspinous space does not open up, so he has a flexion restriction. With my thumb on the lateral aspect of the spinous processes, I'm going to rotate left, checking for joint play between the two spinuses. And then once in pre-tension, I'm going to press lateral to medial on the left lateral aspect, checking for resiliency. I'm going to do the right side to compare. Again, with my thumb on the lateral aspect, but this time on the right, I'm going to rotate the patient to the right, checking for movement, and then once he's in pre-tension, I'm going to spring lateral to medial, and on comparison, the left rotation has less movement than the right, so the patient has a left rotation restriction. Now I'll check lateral bending. Again, on the same side, right side, I'm going to put my thumb on the right lateral aspect. I'm going to have the patient laterally bend to the right, checking for movement between the two spinous processes. And then, once in pre-tension, press lateral to medial, checking for any kind of restrictions or lack of resiliency. Now, switching sides to the left side for the left lateral aspect, I'm going to left laterally bend the patient, and then pressing lateral to medial. I notice from the comparison that the left lateral flexion is also restricted. So the patient has both a flexion restriction, a left lateral flexion restriction, and a left rotation restriction. Okay, if you breathe in for me. And breathe out. Cross your arms against your chest. Breathe in for me. And breathe out. Okay, cross your arms again. Alright, when assessing the patient's thoracic area, I noticed a stiffness in the T8 area, so I stopped to assess it. Placing my finger in the interspinous space between T8 and T9, I flex the patient and then extend the patient. During flexion, the space opened up, but during extension, the space did not close down. So I went ahead and did a rotation evaluation. I rotated the patient to the right with my thumb on the right lateral aspect of the spinous processes. I brought the patient to pretension after checking for movement between the two spinuses and pressed lateral to medial and felt good resiliency. I went to the left side and did left rotation with my finger on the left lateral aspect of the spinous processes, checked for joint play, and then brought the patient to pretension and pushed lateral to medial and noticed that there was good resiliency on that as well. So I went to left lateral flexion. I bent the patient to the left, and with my thumb still on the lateral aspect of the spinous process, pushed lateral to medial, feeling some resistance and a lack of resiliency. So I went to the right side to compare. On the right side, with my thumb on the right lateral aspect of the spinous processes, I bent the patient laterally to the right and then pressed lateral to medial, feeling good resilience. The patient presented with a left lateral flexion restriction. Okay, if you breathe in for me, and breathe out. You cross your arms against your chest. Breathe in for me. And breathe out. Okay, cross your arms again. Next, I assess the repair, going up 2 interspinous spaces and 2 inches out laterally with tissue pull. I checked first for elevation of the rib. I had the patient inhale, checking for an opening up of the intercostal space, and then I had the patient contralaterally flex with a slight rotation and pressed on the inferior aspect of the rib, inferior to superior and slightly lateral to medial, checking for resiliency in the joint. Next, I checked for an extension restriction. I had the patient exhale, and then also with an ipsilateral and slight rotation posteriorly, had the patient, with my thumb on the superior aspect of the rib, pressed superior to inferior and slightly lateral to medial, checking for resilience in the joint. Neither rib had any kind of restrictions. Thank you. Right. Occiput with my thumbs on the top of his head and my fingers about his mastoid process and around the base of his skull. I'm going to have the patient stick out his chin to put the cervical neck into extension, and then put the occiput into pretension. And then I'm going to push superior to inferior on the top of his head, checking for a restriction or lack of resiliency and in-play. Next, for flexion, moving my hands slightly forward, I'm going to have the patient tuck his chin, getting the flexion out of the cervical, and then pushing superior to inferior, checking for restriction and resiliency in in-play. Next, I'm going to rotate the head to the right, getting it into pretension, and then pressing superior to inferior, checking for any kind of restrictions. And then again to the left, this time in pretension, pushing superior to inferior as well. Now for right lateral bending, I'm going to tilt the patient's head slightly, keeping his nose in the same plane, then pressing superior to inferior, slightly lateral to medial, and then again on the left side, the same, superior to inferior, lateral to medial, with my segmental contact point at the top of his skull.